I'm going to talk today about the title of my talk is There is no limit to total arterial grafting. I would first like to thank the Society for the great privilege of taking part in this very important scientific symposium. I'd also like to say it's a great pleasure and privilege to follow Professor Buxton because he's undoubtedly one of the great pioneers in this field, and his work has been very inspirational to me, both in terms of my academic and clinical practice, so I'd like to acknowledge that from the outset. I would also like to say, with the title of my talk, There is no limit to total arterial grafting, it's obviously intended to be slightly provocative. And the reality is, as Professor Buxton said, we don't have any real large-scale trials to answer this. So my talk's going to be in two parts. The first part is going to try and underpin the scientific rationale for the use of more arterial grafts, and particularly bilateral internal mammary arteries in most patients. And the second part of my talk will address why that approach may have specific advantages in the elderly. I do have some conflicts of interest. I'm a cardiac surgeon, I'm an advisor to Novadac, and I'm an advisor to Medtronic, although I don't think any of these really impact on this talk. In terms of the title of the talk, the first thing to state is there are actually a few limitations to total arterial grafting. There are patient-related factors. Obese diabetic patients, not diabetes per se, but obese diabetic patients. Those with severe chronic obstructive pulmonary disease, and those on long-term steroids or immunosuppressants, because these factors all interact to impair sternal wound healing. There are also technical factors to consider. The large right coronary artery with a moderate stenosis, the only thing that works in this situation is a vein graft. If you use an arterial graft in this situation, it will almost certainly occlude due to competitive flow. There is the uncommon scenario of small caliber internal mammary arteries, and sometimes radial arteries are also inadequate. But advanced stage per se, as I will show you, is not a contraindication to the use of arterial grafts. I think it's also very worthwhile pointing out, maybe not to this audience because most of us know this, but certainly when we speak at cardiology conferences, that CABG is still the best therapy for most patients with severe coronary artery disease. It was firmly established in the meta-analysis by Yusuf and colleagues in The Lancet in 1994. I subsequently updated new studies that appeared after that, and with particular comparison to PCI, and most of these studies proved that the seminal conclusion of Yusuf was still valid in today's practice, not only for 3-vessel disease, but for most patients with left main stem stenosis. And encouragingly, it's still true as shown in the 2-year results of Syntax. Now, these will be discussed in detail on Tuesday morning, and I would recommend you attend this session if possible. But what Syntax has shown at 2 years is that at least 80% of patients with 3-vessel coronary disease do better with CABG, and at least 2/3 of those with left main stem stenosis. The question, of course, is this true in the elderly population? It's also important to acknowledge that conventional CABG does have 2 limitations. The first is the damaging effects of bypass, and this is due to a combination of microemboli, flow abnormalities, the systemic inflammatory reaction syndrome. It leads to biochemical dysfunction detectable in all organs. There is overt clinical morbidity in around 15% of patients, particularly affecting the brain, the kidney, and the lungs. And cardiopulmonary bypass mortality and morbidity are strongly age-related phenomena. And the solution to this is primarily off-pump surgery with a no-touch aortic technique, or perhaps increasingly the use of minimal extracorporeal circuits. The second main problem, the one I'm going to address today, is that of vein graft failure. We know that this occurs in 75% of patients. By 10 years, the vein graft will either be blocked or severely diseased, and this contributes to late mortality, recurrent angina, the need for reintervention in 1/3 of patients by 12 years. It's been argued that there may be better results with aspirins and statins, but that is by no means yet proven. But the solution to this is total arterial grafting. And we all have to appreciate in the surgical community that vein graft failure is still a common problem. In this paper published in the New England Journal this year, they looked at 3,000 patients, of whom approximately half had endoscopic vein harvesting and the other half had open harvesting, and the two groups had relatively similar baseline characteristics. But notice that within 12 to 18 months, 47% of vein grafts harvested endoscopically had failed, as had almost 40% of those done with the open technique. And this actually then contributed to 3-year death rates with respectively 7.4 and 5.8, a hazard ratio of 1.5. So vein graft failure is still a common problem. The authors of this paper concluded endoscopic vein graft harvesting is independently associated with vein graft failure and adverse clinical outcomes. Now, the survival benefit of a single internal mammary artery was first firmly established in this landmark paper from the Cleveland Clinic more than 2 decades ago, when they showed that 10 years after CABG, an IMA to the LAD reduced the risk of death, myocardial infarction, angina, and the need for redo surgery. And they attributed this to the fact that up to 95% of internal mammary arteries were patent at 10 years, in comparison to only 25 to 50% of vein grafts. But since then, there's been abundant evidence that the same holds true for a second internal mammary artery. It's been shown by the Japanese, by Professor Buxton's group, and by Antonio Calafiore. And this survival benefit of the internal mammary artery extends into the second and third decade of follow-up. And we can make this fairly basic conclusion that if it was not for the internal mammary artery, there would probably be no coronary artery bypass grafting today. But is there a survival benefit with 2 internal mammary arteries? In The Lancet in 2001, we published this systematic review of studies comparing bilateral and single internal mammary arteries. And from the literature, we identified more than 4,500 patients with bilateral IMA, more than 11,000 with single IMAs, and importantly, we matched these patients for age, gender, LV function, and diabetes, because these 4 factors by themselves predict likely longevity, even independently of knowledge of coronary artery disease. And we found that the hazard ratio for death with bilateral IMA grafts was 0.8, and that's a fairly powerful effect because it translates into a number needed to treat of 13 to 16 patients to have 1 extra long-term survivor. Despite all this evidence, the use of arterial grafts in the UK, Europe, and United States, with the exception of a single IMA, remains stubbornly low. In the United Kingdom, we can see that 95% of patients will receive 1 single internal mammary artery, but fewer than 20% of patients receive 2 arterial grafts, and the majority of the second arterial grafts are radial arteries rather than the second internal mammary artery, and a radial artery is not an internal mammary artery. Only 3% of patients in the United Kingdom received 3 arterial grafts. And we have to ask the question, we, the cardiac surgical community, sometimes criticize our cardiology colleagues on the basis of their practice, but we have to ask ourselves this fundamental question. If a decade ago we had made the standard CABG operation 2 internal mammary arteries rather than the single IMA, would coronary artery bypass grafting be in a more secure position today? And if we ask the question, why do cardiac surgeons not perform more than 1 arterial graft, we conducted a postal survey in the UK in 2002. We wrote to every United Kingdom cardiac surgeon, and we asked them all what was their practice of arterial grafts, and 2/3 responded. 2/3 said there was evidence to support the use of bilateral IMAs. Half of the surgeons said that at least 50% of their patients would benefit. But 2/3 crucially said that if they were undergoing CABG, they would want bilateral internal mammary arteries. Yet this was at great variance with what they were doing in their own clinical practice. And the most common reason for not using them was the threat of increased mortality and morbidity. Now, increased mortality is certainly not the case. In fact, bilateral IMAs may reduce early mortality by eliminating some of the mortality due to early vein graft failure. The most worrying morbid complication is, of course, sternal dehiscence, but there is no evidence of an increase in sternal dehiscence if you skeletonize both mammaries and you avoid the obese diabetic patient. There is obviously a learning curve to using 2 internal mammary arteries, and the operation adds about 20 or 25 minutes to the conventional operation, but this is pretty small beer in a 2.5 to 3 hour operation if this really does lead to improved survival in patients. There have currently been 2 randomized trials of arterial revascularization. The first is the Caracas trial, which was actually organized from Vienna by Paul Simon. It was conducted in 14 centers in 7 countries, and the randomization was total arterial grafts versus a single IMA in veins. 800 patients were recruited between 1999 and 2004. The exclusion criteria were patients over 70 years or those done off pump, and the primary outcome was MACE at 5 and 10 years. Now, regrettably, the only publication from this study has been an abstract that was produced soon after the conclusion of the trial, and there has been nothing subsequently since that. In the United Kingdom, we conducted a trial funded by the Medical Research Council and the British Heart Foundation. We recruited over 3,000 patients in 28 centres in 7 countries, and I'm delighted to say Professor Buxton was one of the key recruiters to this trial. And we randomised patients a single internal mammary artery plus supplemental saphenous vein or radial arteries versus bilateral internal mammary arteries. Recruitment ended in December 2007. This trial was powered with 90% power to detect a 25% reduction in mortality at 10 years. So that's half the effect we reported in The Lancet. What I can tell you is that the 1-year results of this trial are being currently analysed for submission for publication, but it's a remarkable observation that in 3,102 patients, the 30-day mortality was 1.2%. If we now turn to the question about advancing age, there is no question that the population and the patients are getting older. If we look at UK government statistics, we can see that the average life expectancy of a 75-year-old is now over 10 years, and that's increased from 7.7 years only 2 decades ago. Now, I would commend every cardiac surgeon in this room to try and get hold of this book. This is the 6th National Adult Cardiac Surgical Database Report. It's been edited by Ben Bridgewater and Bruce Keogh. It contains over 500 pages of data and analysis, and it looks at all cardiac surgery performed in the United Kingdom in the 5-year period 2004 to 2008. It covers all types of operations, but within it are the results of over 114,000 patients undergoing CABG in that 5-year period. And the remarkable observation is that the total mortality, including urgent and high-risk cases, was 1.8%. But if you look at CABG outcome in over 78,000 elective patients, the mortality for the whole of the United Kingdom is 1.1%. So this is a testament to the safety and efficacy of current coronary artery bypass grafting. If we turn and focus more on the elderly patients, if we look at what was happening in the 10-year period 1999 to 2008, we can see that over that period, the proportion of patients who were aged over 75 increased from 10% in 2000 to over 22% in 2008. So over a relatively short period of time, a very significant increase in elderly patients. And for CABG patients now, 25% of CABG patients in the United Kingdom are over 75 years, and 4.4% are over 80 years of age. Now, if we look actually at characteristics of 80-year-olds undergoing surgery, this is a paper from Berdacchi et al. In Annals in 2007, and they compared the baseline characteristics of over 8,000 patients over 80 years of age in comparison to younger cohorts of patients. And they found that the proportion of females was much increased at 42%. The incidence of renal failure was higher. I'm afraid these red circles have all moved a little bit, but the basic points to try and make is that there was a far higher incidence of carotid disease. Notice that 34% of patients had left mainstem disease. Notice that 2/3 of patients underwent urgent coronary artery bypass grafting, and note that the rate of off-pump surgery was 32%, significantly higher than in the younger cohorts. Now, if we go back to the UK data, this looks at CABG mortality and age in over 112,000 patients in a 5-year period. And what you can see is that CABG mortality, not surprisingly, increases with advancing age. In patients under 60 years of age, the overall mortality is less than 1%. But if you look at the group, the 75-year-olds, I'm disappointed in the colours they chose to make these beautiful slides, but nevertheless, this is the 75-year-olds, and these are the 80-year-olds. And you can see that in the 5-year period, mortality in 75-year-olds has fallen from 4% to 2.8%, and in patients over 80 years of age, from 8.2 to 5%. If we go back to the Berdacchi paper and look at the morbidity following coronary artery bypass grafting in patients over 80, the incidence of stroke is 3%, the incidence of reoperation for bleeding 2.4%, renal failure in 2.5%, but notice also 7% of patients had respiratory failure. If we look at duration of post-operative stay in over 107,000 patients in the United Kingdom, the mean post-operative stay in 80-year-olds is 12 days, so almost double that of patients under the age of 60 years of age. And these figures are almost identical to what's reported by Berdacchi. The mortality in patients over 80 years of age, 5%, and the length of hospital stay, 14 days. Now, Berdacchi made another very important point. When you looked at the discharge of 80-year-olds from hospital, if you were under 50, 96% of patients went home. But notice in the over 80 population, only 50% of patients were discharged to home care. If we look at intermediate term survival at 5 years, it's not bad for patients over 80. Almost 70% of them are still alive at 5 years. And this again mirrors the results from the United States. If we look at the survival of octogenarians in the United States, it's almost 60% are alive at 5 years. If we look at the patients who have had coronary artery bypass grafting, it restores this population to that of normal age and sex-matched controls. Now, if you look at complications from CABG, the most worrying thing is undoubtedly new post-operative stroke. In the UK, in over 95,000 patients, we can see that the incidence of stroke for elective first-time CABG is 1% in 2008. So that is very similar to what was noticed in syntax in the immediate peri-procedural duration. It was just 1.3% in syntax. However, if you do have a stroke, it increases your mortality from under 2% in patients without stroke to somewhere between 8 to 16%. It, not surprisingly, significantly increases hospital stay by threefold, from 7 days to 21 days, and it significantly impacts on long-term survival. Now, patients who have strokes already have higher risk factors in any event, but the addition of a stroke also further decreases their long-term survival. And if you look at the risk of stroke, it is absolutely proportional to the burden of aortic disease. I've summarised 9 studies here involving almost 5,000 patients looking at the impact of aortic atheroma on the risk of stroke. And every single one of these studies shows that aortic atheroma is the best predictor of stroke. If we're trying to find aortic atheroma, epi-aortic ultrasound is much better than TOE, which is much better than manual palpation for detecting atheroma. But all of these studies showed in one form or another that modification of aortic manipulation reduces the risk of stroke and cerebral microemboli. And this is consistent with the fact as shown by Newman in Circulation in 1996 that advanced age and therefore more aortic disease is the strongest predictor of stroke. Now, if you look at what this means for us in practice, here are a number of cartoons of possible ways of revascularizing the heart. The first shows the conventional mammary artery and 2 vein grafts. Notice, obviously, the vein grafts have to be attached to the ascending aorta. Here's a composite bilateral IMA to the left side with a radial artery again attached to the aorta. But in my own practice, most of our CABG operations are based on this technique. 2 in situ mammary arteries. We use the left mammary to the obtuse marginal. The vast majority of these are done off pump. And we keep the right internal mammary artery and cross it to the LAD. And we tend to take composite grafts from the internal mammary arteries. So that allows us to do these operations off pump and without touching the aorta. More recently, we've adopted this technique, which is at preserving the in situ mammaries, the left mammary to the obtuse marginal, the right mammary to the LAD, and then we take the radial artery from the distal LAD, run to the PDA, as long as there's significant disease in either the right coronary artery or the PDA. And this is a fairly straightforward operation, and I think it has an advantage in that it avoids a technical problem of anastomosing radial arteries to internal mammary arteries, where this causes a potential problem of Steele syndromes. Does this actually reduce the risk of stroke? This is a paper by Calafiore of almost 5,000 patients. They looked at 2,800 done on pump, and with the conventional cannulation, cross-clamp and side biting, the incidence of stroke was 2.3. By using composite arterial grafts on pump and avoiding the side biting clamp, you reduce the overall risk of stroke by 1%. In almost 2,000 patients done off pump, the use of just a side biting clamp caused a risk of stroke of 1.1%, and the avoidance of all of these manipulations of the aorta, just using a no-touch aortic technique, brought down the risk of stroke to 0.2. That has now been confirmed in several other studies in the literature. And if we look at large databases of off-pump patients, Wasundra in JACC in 2005 looked at 268,000 patients and found that those in propensity-matched patients done with off-pump surgery, the hazard ratio for stroke was 0.6. Hannon looked at almost 50,000 patients from the New York registry, the hazard ratio for stroke done off-pump, 0.7. And Puskas, in a paper published in Annals this year, looked at 42,000 patients. The hazard ratio for off-pump surgery for stroke, 0.65. So remarkably consistent figures about the reduction in the risk of stroke just by doing these patients off-pump. And I have to emphasize, most of these did not use a no-touch aortic technique. So the results would be even better if you avoided all aortic manipulation. So to summarize and conclude, I think today we can say that arterial grafting should be the basis of most coronary artery bypass grafting, and there is, as I've shown you, still continuing evidence of high failure rates of saphenous vein grafts. I believe that over 90% of CABG patients should receive two internal mammary arteries because the best available evidence suggests that there is a survival benefit for this operation, and particularly in younger patients. Where you have to be cautious with this approach is in the obese diabetic patient, those with bad lungs, and those patients on steroids or immunosuppressants. We have a rapidly growing elderly population undergoing cardiac surgery, and these patients are at significantly increased risk of both death and CVA. I think the current evidence shows that by having the basic component of the operation in this population, bilateral internal mammary arteries, this permits off-pump surgery, which itself reduces the risk of death in this population, and it also permits a no-touch aortic technique, which significantly reduces the risk of stroke. On that point, I'm going to conclude my talk. I would like to thank the organisers again for the very great privilege of taking part today, and the audience for your attention. Thank you.
Thank you, David. I'd like to invite Professor Buxton to join you at the podium, and we have time for a few questions. While people are coming to the microphones, I'd like to ask both of you, and I think it was on one of your slides, David, that aging also induces skewness in the gender distribution. I mean, we have many more aging females than males, so I wonder whether gender effects are pertinent to this discussion.
That's an excellent point, and I think the Berdacchi paper showed that 40% of their patients over 80 were females. In the United Kingdom, we haven't quite seen that effect yet, but we all know that there's a general perception that women do not get the same access to coronary revascularization. We don't do as many operations in females. And I guess what you're alluding to here is that in females, bilateral internal mammary arteries may not be such a good option because they can be much smaller. But I take that point well. Brian?
I suppose the estrogen effect wears off at the age of 50 or thereabouts, and that then puts them back in the same risk ratio as that males.
Question in the back. Sorry, I can't recognize you. But
Miguel Sousa from Lisbon, Portugal. First of all, I would like to congratulate both Professor Buxton and David for their fantastic presentations. And I would like to stress that, of course, all of us here try to avoid morbidity and mortality in this subset of patients, in older patients. But my question is, I think not all patients are equal, and not all grafts are equal, as Professor Buxton stressed. And the point is that saphenous vein grafts are different from patient to patient, as are radial arteries. So I think that the devil is on the details. When you take out, when you harvest the radial artery, the way you harvest the vein also is very important. So I think with this, I would just like to ask both of you, what is the incidence of the radial arteries that are rejected due to calcifications or poor caliber, and what do you think would be the impact of harvesting saphenous vein with a no-touch technique, since we know that open is much better than endoscopic vein harvesting, and so maybe if you adopt a no-touch technique for vein graft harvesting, that may have an impact in its patency. Thank you.
Well, there are a number of issues there. First of all, we do use open techniques. We don't use the endoscopic radial artery harvest, and we're very careful about taking it out, and the senior surgeon normally takes it out, unlike some institutions where it's delegated. With respect to the saphenous vein, again, they're taken out with an open technique, not endoscopically. And furthermore, we protect the grafts particularly carefully between the time of explantation and reimplantation. And finally, we take very careful use of vasodilating substances, many of which you're familiar with, to look at these, to protect these grafts in the time between implantation and recovery of endothelial function, which I think is quite quick, maybe 2 or 3 days. And so we regard that as very important. David?
Yeah. I take your points on board, but I would make this observation. There is a consistent literature going over 30 years showing vein grafts fail, and they're not the same as arteries. I think the recent paper in the New England Journal of Medicine showing that whether you take them endoscopically, you have poorer outcomes than if you do it as an open technique, but even with the open technique, the results are not great. I didn't have time to cover all the data in the literature, but if you look at the randomized trials just now, there is no question radial arteries have better patency than saphenous veins, but radial arteries do not have the same patency as the internal mammary artery, probably because the internal mammary artery is protected by its great production of nitric oxide or whatever it is. But I think the fundamental thing, as I tried to say, is that I think the basis of the operation for most patients, and by most I would say 90% of patients, should be 2 internal mammary arteries, and this should be the underpin what we're doing as a routine operation.
Okay, we have time for 2 more questions. Please, go ahead.
Short one, please.
Ehud Ranani from Israel. First, I would like to thank Dr. Buxton, Dr. Taggart for the excellent talks as usual. But however, I would like to challenge the last line in your conclusion, Dr. Taggart. BIMA permits OPCAG, reduces death, no touch will significantly reduce the risk of stroke. I think that if we take this take-home message, rather than stratifying the patients to the right patients to be operated OPCAP and no touch, I think we're going to increase mortality and increase stroke if we take every patient, especially octogenarians, OPCAG, no touch technique. So I would suggest maybe you can offer us a way to stratify the patients, which are the patients that we should do OPCAB and no touch technique rather than doing it for everybody.
Okay, I have to disagree with you profoundly. I didn't cover the data in the literature for off-pump surgery. There is a ton of evidence that in 80-year-olds, if you do them off-pump, you reduce the risk of death by at least half. There's a ton of evidence that if you do not touch the aorta, you will significantly reduce the risk of stroke. Now, what's the point? If you're operating on very low-risk patients who have, say, an operative risk of 1% or a risk of stroke of 1%, then it's more difficult to demonstrate benefits. But most 80-year-olds, as I've shown you, have risks of somewhere for between 5 to 8% for death and a minimal risk of 3% for stroke. So I think I'm absolutely comfortable with the last line of my conclusion, and I would defend it quite strongly.
Okay, sorry. Let's go to Bruce
Dr. Keogh.
Claudio Muneretto from Italy. First of all, let me congratulate with you for this beautiful review. The question is, you recognize that we first report a randomized trial on the use of full arterial composite graft and the radial artery in composite graft in 2001. Now, since that time, we are advancing the radial artery as with an endoscopic technique. And we use this artery all the time as a composite graft. Can I have your comment about the possibility to use the radial artery harvested in the endoscopic way, and if you feel still that there are some differences when you use the radial artery as a composite conduit or as an anastomose to the aorta? Thank you.
Thank you for that question. I've always tended to use straightforward grafts. And use radial arteries. Probably less than half my patients has a composite, a T or a Y graft. I've never used the jump technique that Taggart just showed you. That looks interesting. Basically, the question you're asking is whether it's safe to use it. What is the exact question that you... Well, I don't have any experience with endoscopic harvest of... we have one or two of our surgeons do in Melbourne, but I don't have any. All I can say is that with an open technique, with very careful surgery, there are no hematomas if you do it very carefully. One of my colleagues removes the collateral veins as well, and it ends up with a beautiful-looking conduit. I think that the surgical aspects of this and the skills and the care and delicacy with which you handle these vessels is probably very critical. And one of the things that makes me wonder is that why our vein graft results are suddenly over the last 10 years much better than they were before. I'm not saying we should go back to them, but certainly with, again, careful harvesting with protection, both intraoperatively and secondarily, I think that probably the veins and the arteries will benefit.
Thank you. To answer your question directly, we don't know. There is no trial, there's no evidence to, but one would, at the back of your mind would be, if veins do not do so well being harvested endoscopically, it would raise in your mind, could the same effect apply for radial arteries? I think in terms of where you attach the radial artery, there is anecdotal evidence they do better if they're put onto the aorta than as jump grafts from an internal mammary artery. However, I would also go on to say that to me it becomes less of a concern if you have put two internal mammaries to the two best left-sided coronary vessels, then I think where you put the radial artery subsequently becomes of less relevance.
Perhaps I could just make one comment. My favourite operation is certainly crossover bilateral skeletonized RTAs for all patients, and that is just a superb operation. The second re-intervention is very rare, except for aortic valve replacement, and even that's not very difficult. So that's my personal bias.
Thank you very much. I'm sorry for the discussion, but we are running out of time, so we have to move to the fourth presentation by Dr. Athanasiou from London, Health-Related Quality of Life After